Good afternoon, everybody. So thanks very much for joining us today. I've brought several people with me today. We're talking about non-specific symptoms in cancer. So thanks very much for coming. So if I could, I'm going to introduce people sort of from left to right. You've got their titles on the screen. So Andrew, if you could wave. Andrew's our gastroenterologist. He's at the North Mid. He's the network director there for non-specific symptoms and for NCL. He's also on the National Clinical Advisory Board for Faster Diagnosis. And what we're about today is all about Rapid Diagnostic Centres and rapid diagnosis for cancer. And then we've got Katerina. Here's Katerina, great, thank you. So Katerina is a clinical nurse specialist in non-specific symptoms, and she is working at the Royal Free. Katerina, I don't know if there's anything else you want to say about yourself before we go on to the next person.
I think I'll describe a bit further down the line my role is, but yeah, I'm the nurse working in the Rapid Diagnostic Centre at Royal Free. One of them. There's two of us.
Thanks very much. And then we've got Mariam Jabbie. Hi, Mariam. So I work with Mariam, as does Andrew. She's a pathway navigator for the non-specific symptoms pathway on the North Mid site for the North Mid RDC. And we've also got in the background Catherine Nestor, who manages, who helps us with all the delivery of all the education programme for the Alliance. And we've got James Harris, who's our project manager for this area of work in the Cancer Alliance. And all of you, so that's great. So I think we'll start off. Can we have the next slide, please? Which I think is James's. Thanks.
Yeah, hi everyone, thanks Claire. Yeah, so just a bit of basic housekeeping that we're all used to now when doing these kind of events. So if you can keep yourself on mute while the presenters are presenting. We've got the chat function open, so please post any questions, queries or thoughts that you might have, and we'll probably come back to those at the end where there'll be a question and answer session. So we'll try and address the chat questions and the live questions at the same time. Thanks very much.
Thank you. So this next slide is one that some of you would have seen before. It's just a summary of ourselves as cancer alliances. There are 21 cancer alliances in England, and we're an NHS structure, and we're sitting parallel and between the ICB and the hospital trusts and primary care, and we cover our 5 boroughs in NCL. Our partners are, as I've described there, so the whole of our community, whether it's patients or non-patients. And what we're really about is doing all that we can to improve earlier diagnosis, support prevention, diagnosis, treatment, and get and also take established innovation in care into practice. So some of the things that we've done over the last year or two that you will know about are in the introduction of FIT into the symptomatic pathway in North Central London, and also work with King's for the UScreen project, which is something we hope is going to deliver national change around cancer screening for cervical cancer. So thanks. So if we move into our next slide, and I'm going to pass over to Andrew, who's going to talk to us about the non-specific pathway. Thanks very much, Andrew.
Thanks very much, Claire. So most of you will be aware of what the RDC is. There is a bit of confusion at the moment about the nomenclature. So the non-specific symptom pathway is the pathway, so similar to the colorectal pathway, but for patients with non-specific symptoms, and it's delivered through the Rapid Diagnostic Centre, and Rapid Diagnostic Centres could accept other types of pathway through that pathway. So the non-specific symptom pathway at the moment is reasonably synonymous with the RDC, but the RDC it's not exclusive. It could take on other ways as well. So what does the non-specific symptom pathway offer? It really is a question of taking on those patients who present in primary care, and the clinician is really unclear as to what the site of the cancer is, but has a strong suspicion that the patient does have cancer. The patients referred to the RDCs can be referred at the moment to 3 different RDCs. So the only hospital in North Central London which doesn't have one at the moment is the Whittington, but they are developing that concept, and we will be working with them to hopefully introduce some form of NSS pathway there too. At the moment it's the North Middlesex, the Royal Free and UCLH. In terms of other pathways, which you could get confused with, there's the AOS pathway and the CUP/MAUO pathway. So what is the difference between the non-specific symptoms and CUP/MAUO/AOS? I think that's just worth highlighting, and there may be questions about that at the end, which happy to discuss. So non-specific symptoms is literally that, those based on symptoms, though it could extend into laboratory abnormalities as well, that it also helped to contribute to the suspicion of possible cancer, for instance, high platelet count or high CRP in combination with those symptoms. What's the CUP/MUO pathway for? That should be really for patients in whom a diagnostic test has already identified a highly likely cancer of unknown origin, for instance, multiple metastases in the liver or in the spine. Those patients should be referred to the CUP pathway. We're aware that, particularly in North Middlesex, there isn't a defined clinical pathway for those patients, and that's currently there's a lot of work going into that to look at how we can provide that better, so that some of those patients would be appropriate still for the RDC, but we need to carefully think about which of those patients might need to be seen urgently, and if they need urgent attention, particularly if there's spinal metastasis, then the SDEX service would be more appropriate. The AOS service is really for those patients who have already been admitted to hospital with a previous diagnosis of cancer, or have been admitted to hospital under a medical or surgical team in whom cancer is diagnosed as part of their admission, and the acute oncology service will help to support those teams looking after those patients. The CUP-MDT is there to discuss patients who've got malignancy of unknown origin, but it is an advisory service, not a clinical service at the North Middlesex. But at both at the Royal Free and at UCLH, there are AOS clinicians who will run a CUP and be more closely aligned with the CUP service, and that, as I said, is being developed at the North Mid as well. So I'm going to go on to the next slide, which is the features and benefits of the NSS pathway in the RDC. So this provides certain identifiable features. First of all, the consultant-led triage. So all these patients will be reviewed by the consultant. The Royal Free, as Katrina will talk to, I'm sure, often the discussion is taken, a review is taken place by the CNS in the first place. At the North Middlesex, we look at the referral. The consultant looks at the referral as the first port of call, and then the CNS will then pick up the service from there. We are trying to develop more one-stop services where we possibly can. That's certainly possible in patients who need one diagnostic service. In other words, often a CT chest, abdomen, pelvis can be often the only investigation the patient needs. So after CNS's evaluation and the review of the CT scan, they hopefully will only then need to be seen once in the clinic. And sometimes those patients can be seen, the scan carried out, and be discharged by the nurse, but that obviously depends on the type of the referral. An important function for this pathway is to avoid multiple cancer referrals. So we would prefer, if patients present in primary care with, for instance, upper and lower abdominal pain, that they're not referred to both upper and lower GI pathways, but they are then simply referred just to the RDC, to the non-specific symptom pathway. Clearly, patients who've got weight loss, sometimes in the past, those were also referred to multiple different pathways, either in sequence or together, and neither is ideal. So patients who have weight loss who go to the colorectal pathway, have a colonoscopy and discharge, come back to primary care, and then referred into the upper GI pathway for a pancreatic cancer to be identified, is not the pathway that we want to see in the future, and we hope to avoid that by guiding those patients to one pathway, that being the non-specific symptom pathway. Naturally, we need to identify what diagnostics carried out and carry them and proceed with those, and then we need to produce a management plan. There is obviously a debate as to how long we keep them under the non-specific symptom pathway. Generally, we prefer to ensure that the patients are not discharged from the pathway until they've got a clear management plan. That management plan may involve further referral to another specialist, or it may involve referral back to primary care. We do not intend to refer patients back to primary care without some form of clear management plan, but that may still need to take place in primary care. So that we may have patients who have weight loss. We've done a CT chest abdo-pelvis, relevant blood tests have been reviewed, the patient has been reviewed, the weight loss is thought to be likely to be dietary, but the patient will need a further review to ensure that the weight loss doesn't continue. That may be something that we'd ask to be undertaken in primary care rather than continue long-term management in the RDC. A key element is the MDT, where we do discuss patients with complex problems, as with other pathways, and we are hoping to have clear communications between primary and secondary care. And I will admit that clearly we want to optimise that. I think the communication pathway between primary and secondary care isn't as good as we could make it, and that's something we can discuss about how to ensure that we do improve that. So I think that when we have patients coming into the MDC, so the RDC, with non-specific symptoms, it's quite often true that those patients have complex problems. They often have a history of mental health disorders. They have a lot of comorbidity. There's a lot of elderly patients in that group, and the communication between us and primary care as to how to best manage those patients would be to the patient's advantage. So we do need to enhance that, I think, for the future. Then looking at the referral and inclusion and exclusion criteria, NHS England have set the referral criteria you can see on this slide. They are new and unexplained and unintentional weight loss, and we have highlighted the unexplained element. There are quite a lot of patients who are referred at the moment with significant weight loss, but it is relatively easy on further history to establish a reasonable explanation, and it's usually a reduction in intake for a variety of reasons rather than an increase in exercise, so that occasionally is the reason. So we would ask you to make sure that those patients are looked at in detail, and if you have got a clear, reasonable explanation for the weight loss, it's not necessary to refer all of those. But clearly, if you still are concerned, then they are definitely patients we want to see, and they do amount to around 80% of our referrals. So that the majority of patients we're seeing with non-specific symptoms are patients with unexplained and unintentional weight loss. Other unexplained and constitutional symptoms are also included, and again highlighting the unexplained. If a patient's got significant depression, has become fatigued, it's probably due to depression and needs treating first. Again, the same with vague abdominal pain, and again highlighting that issue that we'd rather see patients in the non-specific symptom pathway than referred to multiple pathways for investigating their abdominal pain. And then there's this important element. There's a lot of research about gut feeling or GP intuition, as some academics would prefer to call it, but gut feeling has become kind of ingrained in our way of speaking, and it really is very important. It's a strong indicator of a patient having cancer, and some interesting research suggested that the gut feeling by GPs is more reliable the older the GP is, which perhaps is just reflects experience. So it clearly is a very important part of making the diagnosis. So if you can expound why you think the patient might have cancer based on your gut feeling, that will be a very strong indication for us to take the patient. What are the exclusion criteria? Obviously, if the patient has clear site-specific symptoms that should go to an existing single site-specific pathway in line with NG12 criteria, then those patients aren't appropriate for the non-specific symptom pathway. We also don't really want to be seeing patients who are currently being investigated by another specialist team for the same symptoms. We do recognise that sometimes patients' pathways are not fast enough in other pathways, but I'm afraid it's not our role to take over from those other specialist teams when they're already halfway through investigating their patients. There are, however, just to qualify that, there are occasional patients who are referred to other specialist teams, and they come to us and say, actually, could you patient instead? And on the moment, on a named patient basis, we are accepting those patients. This is an ambulatory pathway. We do have 1 or 2 clinics a week. We don't have clinics every single day. We do try and see patients very rapidly, usually within a week or less. But if the patient really needs to be seen urgently, or if they're not able to attend an outpatient appointment, then they're not really appropriate for this pathway, which is definitely an ambulatory one. And clearly we want to be seeing patients who've got multiple types of symptoms. We do recognise that this is an important pathway for diagnosing patients who don't have cancer. So a lot of the patients we diagnose have a serious pathology. About 35% of patients who don't have cancer have another serious pathology, and that's good. It's important that we are here to diagnose those patients. But if it's clear that the diagnosis is not likely to include cancer in the differential, then the non-specific symptom pathway isn't really the ideal pathway. But nevertheless, we are here to help primary care. So if you're worried about a sick patient, then you should refer the patient if the differential does include cancer. And just finally on my section, I'll just go through a slide which we've taken this largely from Manchester, and it's important to try and work out which patients which otherwise would have gone to a site-specific pathway should actually be referred now to the non-specific pathway. So in patients who previously were sent to lower GI, for instance, often did include patients with weight loss, decreased appetite, nausea, bloating, and non-specific abdominal pain. So most of those patients, particularly if they're FIT negative, they should come to the non-specific symptom pathway. We've put iron deficiency in brackets for both upper GI in the site-specific and lower GI in site-specific and in non-specific and in upper GI. And the reason for doing that is because at the moment we recognise that at the Royal Free there is an iron deficiency pathway, which is excellent, and we probably need to look at setting a similar pathway up with a nurse consultant as they have at the Royal Free at the North Middlesex. But at the moment we do ask, certainly for North Middlesex referrals, to use your clinical intuition as to which you think is the most appropriate pathway. That can include the non-specific symptom pathway if you think the patient could have upper or lower GI bleeding, again, particularly if they're FIT negative, if they're FIT positive, or if they've got predominant lower GI symptoms, then the colorectal pathway is probably the most appropriate. And clearly if they're FIT positive, then those patients should definitely be referred. Do bear in mind that the FIT test is not as discriminant in patients who've got iron deficiency anemia. So if you've got a low hemoglobin and a negative FIT, you may still have a colorectal cancer. In hematology, if you think the patient is definitely or highly likely to have a lymphoma, again, that's a pathway would still be appropriate. So widespreading lymphadenopathy would be reasonable, but patients with pure inguinal lymphadenopathy who've also got other constitutional symptoms, particularly weight loss and night sweats, may be appropriate for our pathway because they're likely to have a non-lymphomatous diagnosis. In the ovarian pathway, again, the gynecology pathway often did see patients with very non-specific type abdominal symptoms, and particularly those with a normal CA125 should be perhaps redirected to the non-specific symptom pathway. And in patients from A&E, we are definitely seeing a few patients who are seen in A&E with non-specific symptoms, and they're being diverted to our pathway rather than to the upper GI pathway or other pathways. So again, happy to discuss this slide. We might want to come back to that at the end. So I'm going to hand back to Claire now to talk through the process of making the referral on the NSS pathway.
Thanks. So that the referral is much the same as other referrals. Perhaps if you could swap slide, that's great, thank you. In that you find the referral form in Bar Global. The really important thing, I think, is that the diagnostics are not always simple. So it's really important that we have a set of what we call filter function tests. And that you can find that via TQuest or ICE, however you do your requesting. And they should exist as one button, but essentially if for whatever reason you can't find the button, what they comprise is, I think, do we have a slide later on the full set of tests? Just go down to slide 12, I think it's there. Is it? Just for a second. So yeah, if on the right in the blue box. So we'll come back to that in a minute, but those are the tests. And so if we can go back again, that's lovely. And and it's often really helpful to have a fit test done as well, and make sure the fit answer has gone into the referral form. So it's very, very helpful for us if that's done beforehand rather than afterwards or in the middle of the referral. It's really, really important to meet the patient face to face, partly because we believe that you're going to get more information from them in the end, and also it gives you a really important opportunity to properly examine patients. We can see from the referrals that sometimes it's not been possible for GPs to do this, but it is hugely helpful for us, and we firmly believe that it allows us to get to a diagnosis more quickly, and you to get to a diagnosis more quickly, and so the signposting through the appropriate pathway is much more likely. You're going to find the clinic on ERS, or your secretary is going to find the clinic on ERS, and you need to select the RDC that you want them to go to, so that might be the Royal Free or the North Mid or UCH. And it is submitted via ERS. So managing the form is on ERS, finding the form initially and filling it in is on Bar Global. Now, just quickly, if you go to the next slide, this gives you a view of what it looks like to book. Of the people that are on the chat, can you wave if you actually do the ERS side of it yourselves, or do you give it through to admin, or just say? I'm just interested if most people, perhaps I work in, it goes through admin. I don't know who does it themselves. Yeah, mostly admin. So Emily, you've got a question. Do you want to speak your question? In fact, if you hang on a second, because we're going to come to that slide in a second, and then I'll just bring you back in to talk about that. If we go down to the next slide, completing the form is much like completing any other forms. The information on the slide is all really important, but the really useful thing is to be able to put some narrative of your summary question and your diagnostic findings into the form. And there's a little box which is easily missed where you can write quite a lot of information, and it'd be really helpful if you regarded that like a referral letter, so that you give us a synopsis of the presentation of your findings and why you feel the RDC is the best place for that patient to go. If you only rely on the download of the clinical previous consultations, it can be sometimes difficult for us, because EMIS will or the admin person producing the form in terms of making it ready to send off to ERS sometimes changes the amounts of consultations are in that referral, so it's difficult for us to see the full story. So if you can, please put something, a proper summary into the form. And in fact, if you go to that, I think that's the next slide, is it? Yeah. There's a red arrow that you can see in the top of the middle form, which is a little box which will expand to allow you to talk about the patient, why they've come to see you, what you've found, what your concerns are, and what you're looking to us for. I know the form at this distance on this slide looks rather busy. A lot of it includes sort of WHO frailty guidelines and various other things that you need to fill in. But overall, it's roughly the same as any of the other 2-week wait forms. But the important thing for us, as I said, is that you get the opportunity to examine the patient, and you are able to populate that top box. Thank you. Right, so I think going on to the next one is you, Andrew, you're going to talk about filter function tests again. And then we can come back to Emily's question, which is around, I don't know if you can see it, but I can read it out, which is about, she's talking about, does the form specify they must do fit, chest x-ray, PSA or CA125 prior to referral? Yep. So happy to go with that. Thanks.
That. Yeah. So what investigations we should do? Why are we doing investigations performed? What investigations to do is a matter of debate. This was discussed in national meetings, which I was part of, and there was a strong opinion that there should be a robust and comprehensive set of tests done prior to referring patients to the non-specific symptom pathway. The main purpose of these tests is not to ease the work of secondary care. The idea is to identify those patients who didn't need a non-specific symptom referral because something else had been picked up on the tests. So I think it is quite widely recognised in those of us who are delivering non-specific symptom pathways that forcing everyone to have all of these tests is not practical and not required. So it is likely that in due course we will be skinnying down the really absolutely vital tests to be done to a smaller group, and the other tests will be optional and made and appropriate per the patient's needs at the time. So I hope that covers Emily's answer, but I'm very happy to discuss it. So the really important tests are a full blood count, urinary and electrolytes, calcium, liver function tests, and if there's weight loss, thyroid function tests. It is really useful to have the FIT test. We have had a number of patients who've been referred with not really specific or very non-specific type symptoms who didn't come with a FIT test, who've often, because the patient found it difficult to do it, which we eventually got done or done the colonoscopy, and they've got colorectal cancer and their FIT test would have been positive or was positive. So I think we need to work harder, if we can, at getting the FIT test done in primary care before they're referred. I think that's a challenge both in this pathway and in the colorectal pathway. We do understand that.
Oh, you're studying. Yeah, it's no.
It's all right. Keep on mute if you can. Sorry, Andrew. Yeah.
So the FIT test really is very important, and we do recognise, as I said, the challenges of getting patients to undertake that. And I think as part of the colorectal pathway, and Claire may have more to discuss about that as well, because she's been very well involved in the FIT pathway, as to how we can improve the number of patients who get that done before referral. If you feel that tests aren't appropriate, that's absolutely fine. Include that in the narrative. We're not going to refer patients back to you or decline the referral because the tests aren't done, but we do ask them to be done because it helps us, first of all, to make sure the patient isn't appropriate for a different pathway, and it does help us in our triage. When I'm triaging the referrals, looking at these results in detail, making it much easier to decide on whether we can get some tests done rapidly through the straight to test RDC nurse, or whether the patient needs to be seen in clinic first, because we don't have enough information to be able to guide our investigations, and that speeds the pathway through. So I'll pass back.
I think I'm going to take some questions from the chat now. We've got a couple of people asking, why is there no amylase on the list?
That's because amylase isn't a very good discriminator of cancer, so we don't use it.
Okay.
Happy to discuss it further, but it's not been suggested as very helpful.
Yeah. And Emily, what you would going back to your question about FIT chest X-ray PSA or CA125. So I think the advantage of doing them earlier, if you're really not sure and the symptoms are very, very non-specific, is that it would allow you to focus your referral down the correct pathway. So if you did it and the FIT was positive, you then switch to a colorectal pathway. If you did it and the CA225 was very definitely positive, and you felt that there were other markers which were pointing you down the gynae pathway, then absolutely you would do that. Remember, with gynae, people, it's preferable to have an image, but it depends how the patient has presented to you. Or you could refer on and say that you were arranging an ultrasound. Any other questions around that?
Sorry, can I just say, I think mine was actually more of a comment than a question. Actually,
oh, sorry, Emily.
I was doing a referral this week and was sort of all set to refer, and then started filling in the form, and then realised there were a couple of things that I hadn't done. And I think it is all really necessary, because we do need to make sure that they're not more suitable for something more site specific. So it was more of a kind of just make sure people remember, if you're planning to refer someone on this pathway, to make sure you have really looked and done all the tests, not to sort of, I hadn't sent the form off, but I think that can happen. You can send the form and then it comes back saying, please do these other things, which I think are all necessary. So
Yeah.
it was a comment rather than a question.
It certainly helps us, and of course most of them are just, as far as the patient's concerned, if they're requested at the same time, they're a single needle, and apart from obviously the fit test, and but I think that it streamlines it, and it really helps for the triaging, because what happens in reality is, we're getting hundreds and hundreds of referrals, and Andrew, our nurses, are triaging those referrals and taking the first steps in the diagnostics that we do, so that we're ordering those often first. And we can't do that to speed up the pathway. And we can't do that if we haven't got enough information from all the hematinics. So yeah, that's really helpful.
Claire, did you want to go to slide 13 and just show the TQuest bundle?
Yeah, thank you. That would be great. Yeah, James, I'll need you to take it. That's it. So this is just an example of where you find the you look at groups, and then you find the RDC investigation as a button. Of course, this list of different buttons, whether it's cardiac or whether it's diabetes or early inflammatory arthritis, as you can see on that screen, they're really helpful. But of course, the list is growing, so it's getting longer and longer. But we all thought it was easier for people to be able to press that button. I hope you all agree on that. But that's where we are with that, and that will then launch those tests. And of course, we're working in a slightly dynamic environment at the moment. You probably all know that there's a big NCL-wide review of how diagnostics are processed from primary care into the lab, and how we request them, and also how secondary care requests them. So that will, at the end, when it's all completed, we'll have a better system. But at the moment, sometimes there will be changes in what things look like, and that's slightly out of our hands, I'm afraid. But if there's anything ever that you come across which is incongruous, then please just let us know. Got James's email at the end, and he'll send it to the right place, or most of you know my contact details anyway, so you can contact us direct if that's easier for you. But when you see things changing, what's happening is that the NCL-wide system is going through this review. If something has changed in it now, then makes no sense, please let us know. George has got another question. Do you want to speak your question, George, about pancreatic cancer?
I wonder whether Claire, is it worth? Should we just do the little vignettes of who does what, and then maybe leave questioning lots of time?
Okey-doke. Yeah, why not? Okay, pop down there then.
Just because I thought just the slide 14, just the one after that one, might just work. Just because this demonstrates how many of our referrals have actually got the filter function test completed, and this is any of the filter function tests. So we have seen, I think it's important to point out, a bit of a drop off in the filter function test being completed before the patient comes in, and that it does make it very difficult. And one of the things that's important to look at is that this is now going to be a 2-way pathway. So in the past, this pathway, it has been possible to reject, and we're in a bit of a crossover where some patients will still be sent back for more information rather than for total rejection. But in the future, patients will have to remain on the 2-way pathway while we do that, as they do with site-specific pathways. So to become even more important that the filter function tests are done. So I think Emily's point about really ensuring that that does happen is really, really important. I didn't highlight the tumour markers. I do think the tumour markers are relevant to the type of presentation. It would be useful if all older males had a PSA and all older females had or females with abdominal pain or weight loss had a CA-125. It sometimes can be tricky if the PSA is kind of 4.9 or 5.2 or even up to 6 or 7. It may be that that's got nothing to do with their symptoms. So just if a patient's got very non-specific symptoms and a moderately raised PSA but a normal feeling prostate, you might still want to send them to non-specific symptom pathway. But if you feel the patient's more likely to have prostate cancer, then obviously they should go to the urology pathway. And similarly for the CA-125. So tumour markers carried out before imaging can be somewhat confusing and have to be taken in context with the clinical picture.
Yes, so if we stay there just for a second, Andrew, I think it's helpful just to have a look at 2 questions. Sharon, do you want to speak your question, or shall I speak it for you?
Happy for you to go ahead. It was really just a couple of comments.
Yep. Go on. Okay. I mean, basically, Sharon was saying that can be a wait for phlebotomy, at least up to 2 weeks, sometimes longer in some areas, Sharon, unfortunately. And I'm aware and I agree that it's a problem, but I still think within that time frame, and do you agree, Andrew, that it's probably better to get those filter function tests done before sending the referral off?
Yes, I think that's
because
right.
2 weeks we won't be able to gain that back. We'll just keep the 2 weeks ourselves.
Yes, I think that in broad terms that's correct. I think if you've got a patient who's got a lot of abdominal pain, you're really unclear where it's coming from. The patient doesn't need to be seen in SDEC in the next day or two or few days, but you're really worried about them, and you think there's a reason for them to be seen by us, and the patient can't have the blood test or won't have them done for some reason. There may be exceptions, so we can't make it an absolute rule. But in general, most of the patients who are appropriate for our pathway should be able to wait for a week or two for the phlebotomy and for results to come back. Yeah, and I urge you to try and get the test done if you possibly can. I'm surprised that it can take 2 weeks for a blood test to be taken, and that's something maybe that needs to be looked at in primary.
Yes, it's a real challenge for us, and sometimes it's longer, but we're working on it. The other thing, remember everybody, if you put the word urgent, I would usually type it in block capitals into the top of the clinical box, then the providers have agreed already with us across the system that they will take people in and try and do that within 24 hours. So people can attend without an appointment and show the wording which says urgent, and the phlebotomy team, whether it's CLCH or one of the other providers, should respond appropriately. Obviously, it's important not to mark everybody as urgent, and then the system collapses. But that's there is agreement around that. And if that hasn't been your experience, I definitely need to know about it. What we've picked up, it's good that writing urgent on the blood form is good, Emily. We've picked up in some of the other sites that unless it's written in a way that's typed in, as opposed that some of the providers are worried the patients are writing it themselves. So they're looking for ways to understand that it's been written by the clinician concerned. So as long as it's clear that that's happened, there shouldn't be a problem, and that should really speed it up.
Thank you. Sharon's also pointed out that what time interval between the tests is appropriate, and how historical results. Really, that depends on the presentation from the patient. But yes, 3 months is about right. A set of blood tests which is older than 3 months is probably not going to be relevant to that patient's presentation, and in general, we'd probably be looking more like a month or 2 months as the latest appointment, as the latest set of blood.
Yes.
Usually, if those patients have been losing weight over 2 to 3 months, we want blood tests which are fairly contemporaneous rather than historical. And indeed, in some of those patients in whom we have blood tests done which are 2 or 3 months old, we do end up having to repeat them when they come to the RDC. So yeah.
So I guess we're saying, actually, Sharon, in that situation, we're saying that we would like that if you're using the blood test to make a diagnosis, which you probably are, if it's a non-specific symptom patient, a complex patient, you'll need a blood that's more than 3 months old. So in reality, you'll have done it very recently. The 3 months is particularly valid, I think, Andrew, when in other pathways or in other imaging requests, when people may be having contrast, and so the hospitals have asked us for several years to make sure there's at least as a minimum a UNE and creatinine within 3 months. So that's where that's coming from, I think. Thank you.
Yeah, I agree with that. Should we move to the descriptions of each of our roles in the pathway?
Yeah. Yes. Do you want to describe them? Yeah.
So I'll probably describe most of my role. It's obviously the referral comes in through the 208 team in our hospital. It's uploaded to a system we call SIP, and then I triage from that system. And usually we'll either request diagnostics at that point or make it clear which diagnostics I think are likely to be required. And then the patient is reviewed by the CNS. Catherine will describe a slightly different way of managing it at the Royal Free Hospital, which I think is a very interesting model. The management plan is then set at triage, reviewed by the CNS. If the CNS got any concerns, they bring that to the weekly meetings to discuss those patients, the MDT meetings, And then those patients are almost always seen in a face-to-face clinic, but some patients can be reviewed virtually and discharged if the investigations are negative. And that particularly is going back to what I was talking about, the referral criteria. If it's really clear from the referral criteria that this is a patient in whom the GP is concerned about the cause of the weight loss, but feels that the weight loss just needs a cancer diagnosis to be excluded, a comprehensive set of blood tests and a CT chest, abdomen, pelvis may well suffice for us to be able to say we're confident this patient can then be managed further in primary care and doesn't need further RDC attendances. I do have a role, obviously, in helping to manage the lead, both at the North Mid and in NCL Alliance generally. So I'm going to hand over to Katerina now and ask her to describe in detail exactly her role in the pathway. And I will just preface that with saying that this pathway really is different to other pathways, and the CNS doesn't just have a role in the straight test of organising tests. They have a role in assessing the patient and helping to contact the patient during the pathway, and often discharging the patient from the pathway. So over to you, Katerina.
Correct. Sorry. Hi, everyone. I'm Katerina. I'm one of the nurses, the clinical nurse specialists in the Rapid Diagnostic Centre at Wolfrey. There's two of us, me and my colleague Beth, and we do have, I would say, quite a intensive role in this pathway. So slightly different than what Dr. Millar mentioned. We do prepare the triage meetings that we have with a consultant. We don't triage ourselves on our own. We do triage with the consultant, but we do gather all the information for each patient before the meeting, where we present the patient with the results, previous scans that were done, or previous, referrals, recent referrals to other to equate pathways that carry out some investigations that might not be included on the referral process, to make that decision together with a consultant then what the outcome would be. Then we do action the outcome most of the time. So if the patient requires a further assessment, we do, fortunately, we are mainly virtual service. So we do have a lot of telephone clinics, and these are nurse-led clinics. And then we do have a face-to-face clinic for more complex cases that are consultant-led clinics, and that's only happen once a week. Like I was saying, so we do action the triage outcome. If this is ordering investigation, scans, blood tests, we do order them, and we do communicate that plan to the patient. So we do do it via letter and telephone as well. And then obviously we are the main point of contact for the patient between the hospital and themselves. So providing, any complications with appointments, they call us. We help management of their care in general in the hospital, and we do carry out referrals to all the specialities when it's needed. So all the NDT referrals, if that's indicated, post investigations, we do liaise with the other CNSs and the other consultants in the other teams. And lastly, we do communicate with GPs. So if any further information is required or not clear, we try to contact the person or the practice that made the referral to try to obtain that information. And we do communicate with GPs, updating them of the progress of the patient on the pathway. And then finally, the discharge letter, it's also mainly done by us. Obviously, all this, the decision-making process is not a single person process, is always done in conjunction with a consultant. And that's it. You're on mute.
You're always going to do that once a week. That's still in mind. So yeah, I think that really, it's a very clear pathway there. That I think it's very helpful to have that additional information gathering. We at the moment we do it, the consultant triage, and then the nurse will assess the patient. At Royal Free, the nurse assesses the patient and then brings them to a triage meeting. And I think both models have advantages and disadvantages, but I think there is a lot of advantages to the way the Royal Free do it, and we are looking at that as well. So thanks very much, Katrina. I think that's really, really helpful. I'm going to pass now to Mariam.
Thank you.
Mariam Jabbie, who's our navigator, hardworking navigator, and she's going to describe her role in the pathway.
Hello everyone. So my role as the RDC navigator is basically just navigating these patients through their pathway. So just ensuring that these patients are meeting FDS. However, in some cases, because we are dealing with patients with non-specific symptoms, it can get a bit complex. There may be other situations where there might be a delay with CTs, there might be a delay with MRI. Currently, our MRI machine is down and we've just got one machine going. So you can see how that can create a delay in meeting FDS. So the next step would just be to ensure that they're meeting the 62-day target. As well as that, so how I do this is by communicating with GPs and other external agencies such as other hospitals. So for example, a patient might have gone to another hospital and they may have already had a recent CT scan. So it would be my job to try and retrieve those results instead of them having this scan done. It will save radiation and just again save time. Booking a patients in for their first face-to-face appointments, as well as outcoming their first appointments that are booked by the 2-week wait team. There is a current process where we're thinking of making our CNS appointments face-to-face, as there's only so much you can do over the phone. We are thinking to make those face-to-face, as it could again save up time and help these patients meet FDS. Another thing I do is work very closely with the MDT coordinator, so just updating her on where patients are in their pathway, what we're waiting for, communicating with endoscopy and the radiology team just to make sure these scans are booked in time. If a scan is booked in a few weeks' time, you know, me being proactive and ensuring to see if they can bring that scan forward. So just in overall, just ensuring that these patients are diagnosed, they've got a plan, and just ensuring that they don't breach.
Thank you. Thanks. We couldn't manage without Mariam, actually, and she's really brilliant getting everyone through the system for us. I'm thinking that we should perhaps go to some of the clinical questions so we don't miss them, which are really important in the chat team, if that's okay. So George has asked, is a CT abdo enough to exclude bowel cancer when the CT cap is not a CT colonography?
I think the answer to that one is sadly not, I'm afraid. A CT abdomen in combination with a negative fit test might, however, be a very good way of doing it. I think it's important to point out the statistics around a fit test, that the negative predictive value, which is about 99.7%, is very, very high, meaning that if referring a large number of patients to the colorectal pathway, the fit test is going to be a good way of making it clear that very few of those are going to have cancer. And that, so long as they are not anemic and they don't have any rectal masses, etc., or rectal bleeding. If those patients are, however, looked at from the other end, and you took 100 patients with colorectal cancer and you did a fit test on those 100 patients who've been known colorectal cancer, about 8 of them would have a negative fit test despite having a colorectal cancer. So the fit test is an excellent way of helping to exclude colorectal cancer. It doesn't exclude it 100%, and we always have to take into account of that small number of patients who still ought to still need a colonoscopy despite a negative fit test.
I think the data showed, didn't it, Andrew, though, that if you took a really good history and examined them and had an FBC, that 8% fell to nearer somewhere between sort of around about 6, I think, didn't it? So we managed to get significant improvement.
That's true. And also there's the recent research suggesting a second fit test can be helpful as well. So in some patients who have got non-specific type symptoms, you don't think they've got cancer, they've got a negative fit test, you think there's another explanation, then a second fit test can help to exclude colorectal cancer.
Yeah.
I don't know if that answers the question, but the other big area of concern at the moment, I think, is the question of suspected pancreatic cancer in patients with new onset diabetes. And clearly, NICE guidance now indicates that we should be doing CT scans to exclude pancreatic cancer in patients, particularly with new onset diabetes and weight loss. I would suggest that that is something that we should definitely look at. I wouldn't necessarily exclude patients who haven't lost weight. So if you've got an older patient who's got new onset or worsened control of their diabetes, pancreatic cancer should certainly be considered. And further, if patients have got significant weight loss and diabetes, and you think that they might have pancreatic cancer, we might want to actually arrange a CT chest, abdomen, and pelvis, because that patient may have lost weight because of a lung cancer rather than a pancreatic cancer. So we do have to obviously always consider, and I go back to what Claire was saying about really carefully looking at these patients and carefully examining them, taking into account obviously the great pressures in primary care at the moment, that if we can do that, that will help us to ensure that we get the patient to the right diagnostics and the right pathway.
Thank you. Karen, you've got a really interesting case sort of history that led to a question around if a patient was referred to another pathway and then was discharged from that pathway, but the symptoms weren't resolved, could they come to RDC? Do you want to talk a little bit about that?
Yes, thank you. Can you hear me?
Yep.
Yes, it was a case that we had. This is why I brought this question. We had a 54-year-old gentleman with a raised fit test, abdominal pain, and some weight loss, not a lot, who we referred to the colorectal pathway, ended up having colonoscopy and was told it was normal, discharged back to primary care. The problem was, he rightly said to us, well, my tummy pain's still here and I'm still losing a bit of weight. Where do I go now? I then referred him to the upper GI pathway. He had an endoscopy and that was normal. And then you get stuck in the middle in primary care because you don't know where to go. And I think my question is, we had done all the filter blood tests and everything. We didn't know what the answer was. And I wondered whether this is something that the RDC clinic would be prepared to look at these patients for us who slipped through the net. Not slipped through the net, that's not right, but they get discharged back to primary care and then we're left with the same problem because it's not followed up.
You've described the exact reason why the RDC was set up.
Complex diagnostics.
So the paper, the beautiful paper and a nomogram in the BMJ some years ago, which showed this ping pong effect, which has been referred to as of patients going backwards and forwards to different pathways and not getting a diagnosis. And that's exactly why we need this clinic. So essentially that patient would be absolutely ideal to come to the RDC. At which point you might ask, when was that patient appropriate? So I referred earlier to patients who are under a current team and being investigated by a current team, not being appropriate to refer to the RDC without at least not without a consultant discussion between those teams. But clearly a patient who you feel has been referred away or had been down one pathway and you're really unclear where to go next, then absolutely the non-specific pathway is the right approach. Ideally, the site-specific pathways shouldn't just be doing one test. No. Their remit really should be to exclude cancer based on the reasons why the patient was referred. We are aware that a lot of the site-specific pathways do the one test that excludes their, in inverted commas, cancer and not other people's cancers. And again, that's another reason why the non-specific symptom pathway should exist. So you've described it perfectly.
Was that fit very high, Karen? No,
it wasn't. It was about 19.
Right.
But it forced me down the colorectal pathway. I had no choice.
Yes. No.
But that gut feeling is so true. I didn't think he had bowel cancer.
Right. Yeah. Yeah.
Thank you very much.
That's so helpful.
Thank you.
And I would say that I think clearly if such a patient was referred to the RDC, just as I suggested, there are some patients with a negative fit who still need a colonoscopy for a colorectal cancer. I think there are patients with a positive fit who don't, as you've described. So if that narrative in the referral letter really described exactly what your thoughts were and your feelings were, we would trust that opinion and we'd take it forward from there.
Yeah.
Thank you very much.
Emily, do you want to? Emily's got a question about extra sorts of tests, and the answer is yes, we do them. Emily was asking does our remit include MRI, bone marrow biopsy, brain, MRI brain, that sort of thing? And the answer would be that we would do what was required to come to a diagnosis. There isn't any test we've never done, I don't think, Andrew, is there?
No, we've had we've had about I think 2 patients on our pathway, and one which was not in our pathway but closely associated with was patients with non-specific symptoms, some lymphadenopathy, a significant amount of weight loss, and some sweats at night, who actually turned out to have very severe vasculitis, and that was only picked up on PET scanning.
Yes,
so
we've had acute dermatomyositis, I've had myositis, I've had myasthenia gravis, lots of things. Yeah, I mean, I think our we always have to fit in and meet the performance targets that NHS England give us, but I think we try really hard to provide a holistic diagnostic service. George, I can't understand your question. You've written refer CT directly. What were you talking about?
The question was rather a suggestion to what was the name earlier, who said that they did colonoscopy and they did gastroscopy. Well, they should have. Maybe the colorectal surgeon should have done a CT scan already, additionally the colonoscopy. But at that stage, she, as the GP, could have referred the patient directly to CT scan. That's what I mean.
I see. Yes. Yeah. Did you get a diagnosis in the end, Karen? Or not yet?
Yeah. He ended up with pancreatic cancer. Can I say something on that CT? I don't think we should be referring directly for CT scans with that kind of patient. I think that opens up a whole can of worms and lots of anomalies, and they end up, I mean, maybe he would have been a perfect example, but sometimes what happens is you get these reports back that, forgive me, I find quite difficult to decipher because they come up with lots of different things, and I find that really hard. And then I'm going on a journey that I don't really want to be on. That's my personal opinion.
That's can I talk to that, because that's a really interesting point, and Claire and I are both part of a national discussion about the appropriate, I think that's always a London-wide discussion of whether GPs should be given open access to CT scanning as a broad question, and if so, under what circumstances and what remit. And I think that it's a little bit of an anomaly to me. I think that in primary care you have access to quite detailed investigations, including MRI brain, MRI spine, but you don't have access to CT scanning. But I do take the point that when patients do go for CT scanning, there are lots of additional factors that come into play. For instance, the renal function we discussed earlier, the issue about radiation exposure, which needs to be discussed with the patient, and as you're bringing up, Karen, the issue about what to do with reports, which often do quote various anomalies which people will always have inside them, but not necessarily identified by, or the radiologist doesn't necessarily identify the importance of those, particularly angiomyelinomas of the kidney, etc., and pancreatic cysts, etc., and what to do about those. So I think that it's a bit of an open debate. I think there are patients where, I mean, I've got a friend who's a GP and not far from here who says I would get a patient with weight loss, and I do manage to get a CT chest, abdomen, pelvis available from the Whittington Hospital, and they say that's terribly helpful because it means I wasn't terribly worried about the patient, and I don't have to be worried about referring them because they've had a comprehensive CT scan, and I can carry on managing them. So I think there is an open debate at the moment for which I don't think there's a clear answer, but I think in broad terms there are times when it is appropriate, I think, for primary care to be able to request and take forward patients having had a CT scan. But I'd be interested to hear other people's comments on that.
Yeah. Anyone want to say anything about that? I think personally, I think that it's good to be able to have access in certain situations, and I do think it can help us make some difficult diagnoses quickly, but it's almost a case-by-case basis. I think, Karen, I think none of us should do things that we need to practice within our perceived competencies and experience. And one of the things that we have in an RDC is that we have an MDT, so you have the benefit of being able to sit around with a set of people and talk to them about the findings, and that's really helpful. That's not always available in primary care in the same way in terms of the ease of getting a set of specialists together. So I think I completely understand that in many cases it's very difficult, depending on what's written on the report and how the report is written, but sometimes it would be hugely helpful to be able to have a scan, and if that allowed you to be more sure about a diagnosis. But even in that situation, I think if you'd had a CT, if a CT had confirmed a tumour on that man's pancreas, the likelihood is he might then have jumped much more quickly into the right pathway for him. In fact, so quite often people doing colonoscopies in colorectal pathways will also do a CT cap, won't they, Andrew? That's the CT chest, abdomen, pelvis. So I don't know, obviously there were reasons why they didn't do it that time, but it is sometimes done in some units.
No, I think that's right. I think I would ask the colorectal team to step up to the mark a little bit, and if a patient does present with a change of bowel habit and a fit test and weight loss, that they rather than necessarily always referring to the RDC, that they might just do the colonoscopy and the CT cap and decide from if those were normal and the patient was reasonably well. After that, the patient could then be discharged safely back and not being bounced back to primary care without the CT scan. So there was perhaps a bit of a question about the triage of that patient that Karen presented. But we'll just go back to the point made earlier, and that is if there's a case where in primary care the person says, GP says, I think this patient might have cancer, and the pathway they've just been down has not answered my question, then and I still think they've got cancer, then the non-specific pathway is definitely the right avenue to go down.
Is that helpful, Karen? Anybody, everybody? I guess it's a case by case thing, isn't it, to a degree?
Very helpful. Thank you. Thank you very much.
Thank you. And Sarah, do you want to talk? It's always good to hear from people. Do you want to speak your question? If you can, if not, I can read it.
No, it's not just a comment on imaging. So I think with any imaging or whatever test you can do, the easier it is and the more you can do it, the more you do it. And especially when there's a lot of patient pressure. So MRI spines, I'm sure we do, GPs do loads of MRI spines that aren't going to change management. We should make them wait for their physio assessment and do this. But at the end of the day, patients start showing at you for an MRI, so you do it. So I think as well with CT, you'd end up with just like with ultrasounds, with everything, you just end up with more and more incidentalomas and follow on from there. I mean, whether you'd pick up more cancers quicker, and that would be a better thing, maybe. But I think the easier it is to get anything, the more it's.
Yeah, there's no doubt that if we did allow, did enable CT scans to be readily available in primary care, they would be more widely used. The counter argument slightly is that one of the reasons why we have an earlier diagnosis program is and why Mike Richards, that's his name. Mike Richards produced his report is because the availability to CT scanning in England is much worse than it is in the rest of Europe. And it's thought that by allowing patients to get to a CT scanner more easily, because they're either in the community and community diagnostic centres or available from primary care to book directly, that we will improve our earlier diagnosis rate and get better survival rates like they do in Italy and France, because they get more access to cancer to CT scannings. I think you're probably right that a lot of the time that will cause more confusion, and that excess use of that scanning is not going to help anyone. It just exposes more people to more radiation and more incidentalomas, which aren't going to change management, are found. So I think it's a broader question. I think there should be greater availability of scanning at a lower threshold in England generally. How you arrange that and conduct it is the next debate. And I don't think we have a clear answer, but I do agree that just widely opening up CT scanning to everybody in primary care is not the answer for the reasons you've pointed out.
Thank you. We're kind of out of time. I guess we could debate for another hour about that. But it's been a really good conversation, and as an alliance, we're coming back regularly doing different updates. I'm always, if you want to put anything in the chat that you're particularly keen to see shortly, then please do. And any other comments we'll go through and collect them. But thanks very much for being such a great interactive kind of audience.
Can we just show
Lovely
the
speak.
DAR slide with James's email on it?
Absolutely. Yeah.
So
I've just popped it in the chat as well, so it's
put in
there
the chat.
forever.
Oh, excellent.
Yeah.
So James and I are obviously helped to ensure that the ERG, the Expert Reference Group or Directorate for Non-Specific Symptoms, progresses our work forward. We're here to serve primary care. So if you have any points to make that you think should be discussed at the ERG, then please do contact James, or if you've got other questions or clinical questions that need to be voiced, then he can redirect them to me or the appropriate person. So please do contact James as needed. And again, I'll Claire's point. Thank you very much for listening to our discussion, and I hope it's been useful and helpful.
Yeah, and I've put some contact details, and I can't always answer the phone, but do try. Text if I don't pick up is the thing to do. Thank you very, very much. Great afternoon conversation. Thank you. Thanks for your attention and help. Bye-bye.
Bye-bye.
Thank you.
Bye-bye. Thanks, Katerina. Thanks, Mariam. Thank you.